Well, welcome everybody, and thank you for joining for this edition of Cancer Prevention and Wellness. This is a series that's put on by the Cancer Survivors Park Alliance. I spent some time in the Cancer Survivors Park today. It was beautiful, a lot of traffic on the Swamp Rabbit Trail. Autumn was in full glory, a lot of people on the benches, some journaling. So if you haven't recently gone to the Cancer Survivors Park, I encourage you to do so. Obviously, we're doing these in the series virtually, but we're going to try to find some way to do these as somewhat of a hybrid going forward. Just some housekeeping issues. We will have you muted. It's not because we don't want to hear from you. It's just that sometimes we hear from dogs and squeaky toys and that sort of thing, which can be a little disruptive. So we really encourage your questions, and you can ask those, and I'll be monitoring the chat feature, and we'll interrupt our speaker as needed for questions that you pose. The other thing is we do record all these sessions, and in a few days they will be up on the Cancer Survivors Park website, which is Cancer Survivors Park, all one word, all lowercase, .org, and there's a whole library of these recorded sessions under programs. Tonight we have a subject that I'm very passionate about. It's very dear to my heart, and that is clinical trials. Why participate? And our speaker tonight is Dr. Julie Martin, who I've known for a long time and is a dear friend. She's also an excellent clinician and probably one of the most competent people I know. She has been a nurse practitioner for over a decade. She received her doctor's in nursing practice from Clemson. And she now, while it wasn't a big job 30 years ago, is now a pretty big job. She's in charge of all of the oncology clinical research and some translational research at Prisma. So Dr. Martin, she always wants me to call her by her first name, but she is a doctor and deserves that respect. So I will hand it over to you, and we will interact as we go.
Thank you so much, Dr. Jaguar. I appreciate the opportunity to speak with the community tonight about the importance of clinical trials and why participation should be considered. It, for me as well, is a subject near and dear to my heart. I learned a lot about clinical research working with Dr. Jaguar, and it is of super importance to us and to the community and for the future of cancer care. So we'll talk about it tonight. I wanted to start with our agenda today and what we're going to cover: why clinical trials are important, what regulations protect research participants, why diversity is important in clinical trials, some questions to consider before participating in a study, the importance of biospecimens for research, and finally, share some resources for finding a clinical trial should you be interested. So clinical trials are research studies that test a medical, surgical, or behavioral intervention in people. Really, these trials are the primary way that researchers determine if a new form of treatment or a new prevention strategy, such as a new drug, a diet, or a lifestyle modification, is safe and effective in people. Aims of research include testing ways to diagnose a disease early, sometimes before there are even symptoms, finding approaches to prevent a health problem, including in people who are healthy but may be at increased risk for developing a disease, developing treatments and improving quality of life for people living with a life-threatening disease or a chronic health condition.
And I think we've done a really good job from the standpoint of trials which really have helped patients deal with the symptoms of their cancer treatment.
Absolutely.
Yeah, I think that's been a major inroad. I mean, there's been therapeutic inroads as well, but from the standpoint of making what we have administered to patients much more tolerable. That is short-term and long-term side effects, major inroads via clinical research.
Absolutely. I think back to being a new nurse back in 1985 and admitting patients for chemotherapy, giving them Phenergan and lorazepam to just have them sleep through it for 48 hours. And these are treatments that we now routinely give in the outpatient setting because of new and better supportive care drugs to prevent side effects that we dealt with before. So huge strategies and strides being made in that arena. And finally, some research aims to study the role of caregivers or the role of support groups, the role that they play during a patient's journey. So lots of ways to conduct research. So with our focus this evening being cancer, let's talk about why these trials are important. Today, people are living longer lives from successful cancer treatments that are the results of past clinical trials. Through clinical trials, we determine whether new treatments are safe and effective and whether they work better than our current treatments. Do they become the new standard? When you take part in a clinical trial, you add to our knowledge about cancer and you help improve cancer care for future patients. They are truly the key to making progress against cancer. So let's discuss for a minute how studies are typically classified. On this slide, you see some examples of the types of clinical trials. It's not all inclusive, but these are the major classes. So prevention trials. They look for better ways to prevent a disease in people who have never had the disease or to prevent the disease from returning in folks that have had the disease. Approaches can include medicines, vaccines, lifestyle changes. Screening trials test new ways for detecting diseases or health conditions. So, for example, a blood test to detect the presence of cancer, or imaging technology like a mammogram, maybe a procedure like a colonoscopy. Those are screening tests. Treatment trials test new treatments, new combinations of drugs, or perhaps a new surgical technique or a new radiation therapy modality. And then we have quality of life trials. These are often supportive care trials can fall into these categories, like we just mentioned. They often explore ways to measure and to improve comfort and quality of life for people dealing with a chronic illness or health condition. So let's drill down a bit on the phases of clinical trials. So clinical trials are conducted in a series of steps that we call phases. Phase 1 trials, researchers test a drug or a treatment in a small group of people. It may be 20 to 40 people, and it's for the first time. Phase 1 involves drugs that have just come out of laboratory testing, what we call preclinical testing, and are entering into the clinic to be used in people. We are fortunate to have a phase 1 unit in our Cancer Institute and have conducted more than 20 what we call first-in-human trials. So we have actually had the first individual to receive the drug right here in our clinic. Now, the main purpose of a phase 1 trial is to study the drug or the treatment to learn about safety and identify side effects. So although efficacy may be a secondary endpoint, the effectiveness of the treatment is not the main objective because we must learn about the drug and how it's going to behave in humans, how best to give the treatment, meaning on what schedule, what days, how often, and what the side effects are going to be and how we're going to manage those side effects.
And the initial dosing is going to be somewhat of an underdose because we want to make sure that we are monitoring and taking care of the toxicity.
That's right. And then based on the safety in a few people, 2 or 3 individuals, we may escalate the dose from there.
Right.
So again, we're looking at safety and identifying side effects in a phase 1 trial. When interventions make it past that phase, they move into phase 2. So phase 2 involves giving the drug or the new treatment to a larger group of people, maybe 100, 200, 300. At this point, we are wanting to determine its effectiveness and to, of course, continue to study its safety. So it may be that we are looking at the treatment in multiple different types of cancer to see if it tends to work better in a specific cancer, or maybe it works when a specific condition or tumor, something specific to the tumor is involved, a specific mutation, for example. That's phase 2. Then it moves into phase 3, and phase 3 trials are where the drug or treatment is given to large groups of people, 1,000 to several thousand, with the goal of confirming the effectiveness, monitoring the side effects, and the very important component of comparing it to the current standard or to similar treatments. We want to know if the new treatment or intervention is as good as or better than the current standard. If it's better, it may likely become the new standard. But what if it's the same? Well, does it have less side effects than what we are currently doing? What about financial toxicity? Is it more expensive or less expensive for the patient? These are points that are taken into consideration when deciding what is the best treatment. And finally, there's phase 4. This is really often referred to as post-marketing trials. It really isn't as formal as our phase 1 through 3. Rather, it's after a drug or a device is approved by the FDA and made available to the public. Its safety in the general population continues to be tracked so that we can learn more information about the benefits of the treatment and its optimal use in the population. So why participate in a clinical trial? People volunteer for research studies for a variety of reasons. Whatever the motivation, when you choose to participate in a clinical trial, you become a partner in scientific discovery. Participating in research can help future generations lead healthier lives. I mean, major medical breakthroughs couldn't happen without the generosity of clinical trial participants, young and old, healthy, or individuals diagnosed with a disease. Participants are important. Now, if someone is willing to participate in a clinical trial, they likely want to know how are they protected as a research participant. So the Department of Health and Human Services has overall responsibility for protecting the health and well-being of Americans in general, so people in general. But DHHS houses the office that is responsible for enforcing important regulations that are known as the Common Rule. So the Common Rule, it's a short name for the federal policy for the protection of human subjects. It was created back in 1981. It's the rule of ethics in the United States regarding biomedical and behavioral research that involves human subjects. It's because of the Common Rule that we have guidelines that require patients be informed about research and be given options. So the Office of Human Research Protections, OHRP, oversees informed consent and patient safety. Let's talk about institutional review boards, or IRBs. An institutional review board reviews a clinical trial or a study protocol before it starts accepting patients. That is to make sure that the risks involved in the trial are reasonable when compared to the possible benefits, and that the risks are outlined in the informed consent document. So informed consent is a process through which you learn important information about the trial in which you are asked to participate or wanting to consider participating in. It's a critical part of ensuring patient safety in research, because during that consent process, you learn the purpose, the risks, the benefits of the study, and other information that will help you decide whether to join. And then there are data and safety monitoring boards, DSMBs. They monitor the trial to help ensure patient safety by watching that risks that come from being in the study are reduced as much as possible. They also ensure that the data reported is accurate, it's sound data, and they can stop the trial if safety concerns arise. So OHRP really is tasked with ensuring that we protect patients and people willing to participate in research. Let's take a moment now to talk about the importance of diversity in research. You know, people may experience the same disease differently. Where we live, how we live, and our background can all affect our health. So it's essential that clinical trials include people with a variety of lived experiences and living conditions, as well as a variety of characteristics like race and ethnicity, age, gender, sexual orientation, so that all communities can benefit from scientific advances. Unfortunately, there are still challenges today involving diverse representation in research. Therefore, we have to do what we can to address concerns about clinical research, whether that be fear, anxiety, worries about confidentiality, about trust issues. So here are some quotes from individuals describing their concern about participating in research. So Wendell says, I used to hear horror stories, literally from my grandparents, starting with Tuskegee, about what happened, what was done, what wasn't told to our community. So there's been mistrust for years. For those of you that may not be familiar with the Tuskegee incident, that was back in the 1930s, and research that went on for decades where physicians studied the progression of syphilis in low-income African-American men, but the people weren't told that they had syphilis, and that prevented them from learning about their diagnosis, and it prevented them from receiving penicillin when it became available to treat syphilis. And it was just a misuse, and part of the reasons we have such stringent regulations now in how we protect people and ensure that they are in the know and aware of what's going on.
So you've made it clear that the NCI has put up a significant number of guardrails here. We can't deny that there was unethical research being done, and it kind of parallels with other things that were happening at that time in our country's growth, especially in the South. But we've advanced from that, and I think that there's always the situation where sometimes the pendulum swings too far in the other direction. So there's still this hesitancy, which shouldn't really be there anymore. And to a certain extent, it's causing a disservice because we feel like clinical trials are probably the most effective therapy that we have. And some minorities are denying themselves or family members access to it because of past transgressions. So sorry to get on my soapbox there, but it's just one of those things where we have to offer this to the entire population. And I don't want past experiences or past history to influence we've learned our lessons. And I think right now clinical research is as safe as any research. The other thing is when you do clinical research, you have a research nurse, and that person, he or she, is going to be another member of your clinical team and is definitely dotting I's, crossing T's, making sure that they're another person checking up on you. So you're not going to get lost if you're on a clinical trial. So I think it's the best option for how to take care of your disease, and it's the best clinical care that can be given out there. And so we can still live in the past, but we need to learn lessons from the past. I think the NCI has done a good job of learning those lessons, and we have, I think, a safe procedure now, and we want our minorities to take advantage of that.
Absolutely.
Sorry, went off.
Our national guidelines, like you're saying, NCCN, it says your first treatment option to properly care for patients should be a clinical trial if there's one available. So it is denying folks the best treatment option if we're not showing them that we can expand their team, they can trust us, and they have more people in their corner than ever if you're participating in a clinical trial. Another feedback here was that some folks never hear back about studies they've been participating in. Stacy says, she never heard about the studies her son was involved in, and she would love to know what came of it. And that's another reason some minorities don't participate, is that they never hear the results. So I think also now we have ways of keeping folks informed. If there are outcomes, we're letting people know. If there are new side effects, we're letting folks know information as the study is being conducted and after the study is over. So overcoming some of the challenges include researchers partnering with trusted community organizations and individuals for educating and outreaching and recruiting participants. And we need to do a good job of tailoring the message and our study materials to the cultural preferences, the language, the literacy level of the potential participants. All of that can help play a part in overcoming the barriers that we see.
And the other thing is that if you're enrolled on a clinical trial, you can stop the therapy at any point. You can disenroll from the trial at any point.
Absolutely. You're always volunteering, and you are free to stop at any time. So turning our attention now to, for a minute, to the importance of biospecimens in research. Specimens are extremely valuable because they are key in the development of biomarkers, which are a test to know if something is present in the body or in a tumor cell. And they're key in the development of new therapies for treating cancer and other diseases. It's important to check levels of drug in the bloodstream, drawing blood and checking those kinds of things. They pave the way for improving patient outcomes in the future. And I'll highlight the importance of biomarkers and biomarker testing in a clinical trial participant story in just a minute near the end. But biospecimens can include blood, tissue removed during surgery, hair follicles, urine, saliva, other body fluids. All are considered biospecimens and are important in research.
We had to do nail clippings.
Nail clippings as well. That's right. We haven't had to do that in a while. So you've heard about a research study, or you've been approached about one, or maybe you're interested in participating as a healthy participant. What questions should you consider? So during the informed consent process, the study team should be, and ours will, explain the purpose of the study. This should answer your questions about what the research is and why it's being done. You'll learn what will happen during the study and what you will need to do, such as how many times will you visit the study site or come into the office, and any tests you will take, lab tests, any x-rays or CAT scans or EKGs or the like. The study team will explain the possible risks, such as side effects, the possible benefits, and any alternatives, such as the standard of care, the standard treatment, if it's available, or simply choosing not to participate. That is an alternative and always an option for folks. Studies typically protect privacy and confidentiality by assigning a unique participant identifier, such as a letter or number or a combination of the two. That way, the participant is not identified by social security number or medical record number or birthday or personal home address. That kind of information is not available to the researchers. Ask about costs. What will I have to pay for, if anything, in the treatment? What costs would be covered by insurance or would be my responsibility? Tests and medications that are considered standard of care And by that I mean they would be ordered and monitored by your healthcare team and your physician, whether you participated in the study or not. Those are considered standard of care and what is the right thing to do. Those are covered by insurance or are the individual's responsibility. Whereas tests that are performed specifically for study purposes, they are paid for by the study sponsor. Investigational medicines, meaning medicines that aren't approved by the FDA, those are provided without charge to the participant.
So sometimes we, during a clinical trial, perhaps want to do more imaging, more evaluation of what the tumor is doing. And when we're developing the trial, we do give feedback to the physicians developing whether or not, it's reasonable for a person to get say a CAT scan every 2 months. That's probably not within the standard, and therefore probably, if it needs to be done, needs to be financed by the research.
Absolutely. So anything that, like Dr. Gier is saying, is outside of what we would normally do in caring for that patient would be considered doing it for study purposes and need to be covered by the study sponsor. So where can you find clinical trial opportunities? The National Institutes of Health, or NIH, conducts clinical research trials for many diseases and conditions, cancer, Alzheimer's disease, heart disease, among others. So to search for diseases and conditions, you can visit clinicaltrials.gov. It's a searchable registry and a results database for federally as well as privately supported clinical trials that are conducted not only in the United States, but around the world. Clinicaltrials.gov gives you information about a trial's purpose, who may participate, like the eligibility, the general eligibility criteria, locations of where the study is being conducted, and there's phone numbers, contact information where you can call or email for more details about the study. Certainly, your physician is someone to ask if you are interested in participating in a trial or want to know what trial opportunities are available to you. Your healthcare team is also who you should ask. There's also the NIH Clinical Center. They offer trials that are available at clinicalstudies.info.gov. This website is a registry of publicly supported clinical studies. These studies are mostly conducted in Bethesda, Maryland, where the NIH NCI are housed. However, there are options for trials accepting healthy volunteers, and you can actually register on that site as a healthy volunteer. Many times, trials for healthy volunteers may include questionnaires about living environments and lifestyles that they want you to fill out at certain intervals. They may also include biospecimens, like a buccal swab, which is where a kit can be sent to the participant's home for self-collection of a specimen. You swab the inside of your mouth with like a Q-tip, and they have the mailer there for you where you put it back in and you ship it back to them at the research center. And then finally, Research Match. It's an NIH-funded initiative to connect people who are trying to find research studies with researchers who are conducting that type of study. Or it connects researchers who are seeking people to participate in their studies. So Research Match is a free, secure registry to make it easier for the public to volunteer and to become involved in clinical research studies that contribute to improving health for future generations. researchmatch.org.
So one of the things that we have really the luxury of in our area, the Upstate, on Dr. Martin's first slide, there was a emblem for the NCORE of the Carolinas. What NCORE stands for is an acronym for the NCI Clinical Oncology Research Program. So we have one at Prisma. There's probably only, how many NCOREs are there?
30, 32, and maybe
minority,
including the minority base.
Yeah, some minority base, but of the 32 NCORs in the entire country, and then there's a minority based one in Hawaii, there's a minority based one in Puerto Rico. We have one in Greenville, and there's also one in Spartanburg. And St. Francis works with the one in Spartanburg, and I think Anderson ANMED does as well. So there is no place that you go in the upstate where you do not have access to NCI-sponsored trials. So it's not present around the country. We're very lucky, and we're both Spartanburg and the Prisma system are both very high accruers. That is, they're putting a lot of people on trial and therefore getting refunded every 6-7 years. So I think it's just important to recognize that when you're trying to deal with a new diagnosis or a disease that's recurred or something else, it's really important to demand if there's a clinical trial option for you. Our doctors have to do a lot of things, a lot of extra things. There's just more and more things that they have to accomplish in order to have a complete note, and they don't have much time with you. So there's a throughput issue too, and it does take more time to enroll somebody in a clinical trial. But that's something you have to demand. If you're going for a second opinion to someplace in the Northeast, in Boston or New York or MD Anderson or Mayo Clinic, they may say to you, well, your best option is this clinical trial, and they will look up whether or not your own area has this trial. And it's very reassuring when you hear that, yeah, they can do that right there in the upstate. You have access to that trial. So it's just really important for you to advocate for yourself. Not that you will decide that that's what you want to do, but just see if that's an option for your care.
Absolutely. And here are some website addresses if you want to learn more about research participation. It kind of covers some of the things that we've talked about tonight. So at NIH.gov and HHS.gov, there are also links here to printable questions, those questions kind of that I mentioned for you to think about when you're considering a research study. And the question printouts are available in English and Spanish at those websites. So we are fortunate here in the upstate, both Spartanburg and Greenville community oncology programs that are funded by the NCI have numerous clinical trials available to us, and we both have been recognized for outstanding accruals. Just recently, we were awarded for our accruals in cancer care delivery research. So again, that is looking at making sure folks have access to care. And so we're really proud of the team that we have, the team that Spartanburg has in conducting clinical research. So be sure and ask your physicians about that. So I really wanted to kind of end our time today with—
And if I could just interrupt you, not that I haven't been, but at the end of the year, we will be sending out a full calendar of every lecture in the cancer prevention and wellness to our eServe. We are working diligently on the production of next year's schedule. And for the people that are on today, they haven't been real active on chat. So I want you to think about, while Dr. Martin's finishing her remarks, think about a specific topic in prevention, wellness, any specific thing that you'd like to have spoken to over the course of next year. These are 12 series that are 12 episodes that are done the second Thursday of every month. Obviously, we're off schedule this month, but we just like to get some evaluation from our people that we're trying to serve as to what they want to hear about. So if you could do that in the chat box, if something comes to mind, that would be great. Back to you.
So I wanted to end our time today with a real patient story. A 51-year-old female who developed pain and a lump in her neck in the fall of 2015. And she had a biopsy that was suspicious for a rare cancer. And she was sent to an out-of-state center for recommendations. She had surgery there to remove the mass, and it was confirmed that she had a rare tumor called an adenoid cystic carcinoma. She received about 6 weeks of radiation to her neck after the surgery to hopefully prevent a recurrence. And she continued to do well until late summer of the following year. And so as part of a routine follow-up and how we would watch or manage those patients, she had a CAT scan performed. It showed multiple nodules or tumors in both lungs. And a biopsy confirmed that those nodules were adenoid cystic carcinoma that had spread or metastasized to her lungs. And unfortunately, there is no standard chemotherapy that has been found to be effective for this rare tumor. So at that outside facility, she was told that, which is a true statement, and told that this would decrease her life expectancy to probably 6 months or less. And so she returned home to Greenville. She heard about our rare tumor center, and she was really feeling fairly well and shocked at what the CAT scan had showed. And she wanted to consider any possible clinical trials or what could she do. So she was seen and had a new test performed. And that test was performed because of tissue research that had been done on a new biomarker. So this new biomarker test came about because somebody had donated tissue for research, and researchers had discovered a biomarker that could tell if a person might be more likely to certain treatment. So for this patient, we won't get too sciencey, but the biomarker was called PD-L1. And PD-L1 is a protein, and it acts as a kind of brake. It puts a stop on your immune system, on T cells, from getting too hyper when they shouldn't be. So when PD-L1 binds to another protein called PD-1, it basically tells the T cells to chill out and leave other cells alone. Well, some cancer cells have lots of PD-L1, and that helps them hide from an immune attack because the T cells get turned off, and they don't go attacking the cancer cells, to kind of put it super simply. So a treatment was available as a possible option for this patient because her tumor showed a high PD-L1 expression. The therapy involved immune checkpoint inhibitors. So these drugs bind to PD-L1, and they blocked it from being able to bind to the PD-1 that I mentioned. So therefore, the brake could kind of be released on the immune system, and the immune system, T cells, could be free to go and kill cancer cells. So as part of the trial, the patient had baseline CAT scans so we could see what the cancer looked like before beginning treatment. And then after given a number of treatments, CAT scans are often repeated again so we can see what the cancer looks like. So here you're looking at CAT scan images of the lungs. So
if you can move your cursor just to the tumors that you see there.
Yes, so I will. These images are again at baseline, so just before treatment. So when you're looking at these pictures, remember that the patient is lying down on their back. So if my cursor is moving, can you see it? Yeah, so their back is down here. Chest would be up here. Black spaces are typically spaces that are filled with air. So these are lungs. This would be the right side of the body and the left side over here. The big white kind of blob in the middle is your heart. And then here, the lower image is just a slice further down. So I think about CAT scans like slicing a tomato. If you cut a tomato cross section and you're looking down at it, and then you cut another piece and put it over on the plate and you're looking down at that slice, That's what CAT scans are doing. It's like cutting your body across in half, and you're looking downward at the image. So this part of the lungs are normal. These little streaky parts are your blood vessels, and your alveoli are your breathing sacs in the lungs. But what's not normal here are these kind of circular white areas that you see. These are tumors. These little areas. This big one down here. All of these little white spots should not be here. They're individual tumors in her lungs. And if you could see multiple slices from the tops of her lungs to the bottom of her lungs, there were multiple, I mean, just numerous tumor nodules. So again, this was baseline. She started on treatment and she received this immunotherapy infusions every 2 weeks. And after 2 months, which was 4 infusions, now we have, on the left side, you have the pictures I just showed you, the baseline, top left and bottom left. And after 2 months, we have pictures on the top right and bottom right. It doesn't take really a trained radiologist to see that these nodules right here and all of these down here aren't showing up over here. It was truly remarkable. We were blown away. She was blown away. She had one small tumor, about 1 inch in size, remaining after about 6 months of treatment. So she was taken to surgery and had that tumor nodule removed. And she went on to complete a full 12 months of treatment, which was the recommended time frame. And she was cancer-free for over 2 years. We had 2 additional patients, still have, that had complete responses to immunotherapy treatment like this. Truly remarkable in the situations of rare tumors that weren't responding to other treatments or that didn't have a standard treatment option. And this, guys, is why clinical trials matter. For these patients, the clinical trial allowed them more time with their families, more time to reach that next milestone in life, whether it's a child's high school or college graduation, maybe the marriage of a child or the birth of a grandchild. It will make me emotional to talk about this, but this is why we do what we do. Not every outcome is like this, but boy, we sure are glad when there are outcomes like this. Regardless, for these patients, it was a precious time, and for that, we were grateful. They were grateful. So, without research, there aren't advances. There's no discovery. There's not better care for people today or tomorrow. But it takes a village. We can't do it without the wonderful individuals that take that step and say, yes, I want to participate. So ask your physicians about it. Take opportunities, maybe to even be a healthy volunteer. I appreciate the time tonight. I'm happy to take any questions. I'd love to hear any thoughts or comments. Thank you.
So I have one comment about cannot hear. Check on your computer at the volume setting and move your finger over that, and maybe the sound will come in better. You got an awesome, Jules. I love the owl picture. You got to use that. I got to share that with you. That's if people are looking to say questions, you don't even need the word up there. What? So from your standpoint, kind of share with you your last 30 years of clinical research, where you started and obviously where you are today.
Yes.
And the advances that you've seen.
Unbelievable. I think I mentioned at the beginning how back in 1985, we admitted patients for treatments that we give as an outpatient now, because we have wonderful, much better medicines to handle nausea and vomiting, diarrhea, fatigue, those kinds of things. We have so many new treatment options now. We are treating so many cancers as really chronic conditions now. Before that was really a matter of time. lots of times hospice involved, and now we have real quality of life for patients who are, coming and getting treatments intermittently, like taking their blood pressure medication. And I don't at all mean to minimize it. Treatments certainly have their side effects, but it is just so refreshing to see the treatment options that we have now that we didn't have then. The number of opportunities that we've had here locally in the Upstate to participate in research that has led to a new drug being approved by the FDA. We've had, I don't know whether to call it the pleasure, FDA audits are scary, but we have had the opportunity to participate in audits by the Food and Drug Administration. We did that for the remarkable drug called Herceptin, a game changer in the treatment of not only breast cancer, but now we know in some cancers like colon cancer, esophageal cancer, gastric cancer, when it's present, patients sometimes can respond to Herceptin that we would have never given to those patients in the past. Gemcitabine has been around a long time now, but it was letters and numbers when I was a young nurse, and part of the FDA approval of that drug that's the backbone. I remember the first patient that we gave Taxol to, we admitted to the hospital. That patient was in room 351, and we were scared to death monitoring that patient all night, afraid that the heart rate.
That was a 24-hour infusion, right?
Absolutely. Yeah. And now it's the backbone of so many treatments, and we give it without even thinking about that. So a lot of breakthroughs and advances that I've been so privileged to be part of.
And the NCI has a relationship with the University of Rochester as well as Wake Forest University as the major points of doing research in symptom alleviation and quality of life, and some prevention studies. And so there's an aspect of things as far as taking care of the tumor that we want to do, but it's also an aspect of things that we want to investigate about taking care of the patient as well. So I don't see any other questions, but we'll keep the owl up there because I like it. Next month, December 14th, we have a pelvic floor physical therapy person who's going to talk about women's sexual health and pelvic floor exercises. So please alert your patients who have had colorectal surgery, specifically rectal surgery or radiation, and a lot of the GYN malignancies will be affected by this as well, and we'll probably get some benefit from this. So as per usual, I'll leave you with a couple quotes. There's an American astronomer, Carl Sagan, who I think everybody's heard of. And he said, somewhere, something incredible is waiting to be known. And I think that's what clinical research is all about. And then Daniel Borston is an American historian. The greatest obstacle to discovery is not ignorance, it is the illusion of knowledge. We don't know everything. We don't, just because we did it like this in the past doesn't mean that we can't do it better in the future. And clinical trials is what that's all about. So wait a minute, we have a couple of chat things here. Won't leave anybody hanging. Just accolades. So thank you guys. And if there's any way you could probably put a remark in the Cancer Survivors Park website about what other topics you'd like us to cover in next year's series. So thanks very much. We'll give you some of your evening back. And Dr. Martin, thanks so much for helping us out.
Thanks, Dr. Junior. Enjoyed it so much. I hope you guys have a good night and a great Thanksgiving and holiday season.
Right.
Take care.